So this afternoon, we'll be looking at the current data on the management of pulmonary embolism. I will try to integrate both medical and interventional management in an evidence-based medicine approach. So with that introduction, these are the learning objectives. I will discuss with you pathophysiology and therapeutic implications. We'll look at current clinical practice guidelines. We'll look at EBM data. And then we will use illustrative cases to discuss our point. Let's start with this case. So take a look at it. These are the recon. DVT study, positive DVT in popliteal and peroneal vein. And we do a script concordance. So let's do a pre-presentation script concordance. And we will look at the end of the lecture, at the end of the presentation of the EBM data. Let's see how the EBM data influence your management. Did it change your initial management? Did you make the right or appropriate decision? Or was there a 360 or 90-degree turn from your initial decision? So this is what we call a script concordance. I think this is the format that will be given to you in the MOC, examination after 10 years, or I think that's examination after 15 months. We call it the script concordance. This is being used in some training programs, especially surgical training programs in terms of decision making. And I think in Europe, at least in the Netherlands, they're using it in radiology teaching programs. So there are usually 5 categories. Usually +2, it's absolutely necessary. +1 is useful. 0 is no effect. -1 is not useful or even detrimental. And then -2 is totally contraindicated. And now you're given this. It's being referred to your catheter thrombolysis, and you found out the following information. There's right-sided chamber enlargement. What will be your decision? And then later on, you found out that the 2D echo showed a pressure of 70 millimeters mercury. And then later on, they also requested for IVC filter placement. So when you look at the pathophysiology of pulmonary embolism, it is the clot. And what are the consequences of this clot? So depending on the degree of obstruction, there is a pressure overload on the RV. So the RV will distend, it will dilate, and then there is septal deviation towards the LV. Consequently, because of the diminished pulmonary blood flow, there is a diminished blood return into the LA. LA is underloaded, the LV is underloaded, and consequently, there is diminution in your coronary perfusion. And therefore, what will be the goal of treatment for pulmonary embolism? It's lysis. You have to dissolve the blood clot. It has been shown by hemodynamic data that RV hemodynamics and LV hemodynamics are improved with the use of lysis. It decreases the pulmonary vascular resistance. It decreases the RV pressure. At the same time, it will restore the interventricular septum to the normal position. In terms of LV hemodynamics, it will increase the blood flow, and therefore it will bring it back to a normal preload into the LV. It will improve the cardiac output, and therefore it will improve perfusion. When you look at the vicious cycle in acute pulmonary embolism, it starts with RV dysfunction because of the increased pulmonary vascular resistance. There is pressure overload, there's dilation, there's diminution in LV preload, diminution in LV cardiac output, eventually leading to systemic hypotension. And then later on, it will lead into coronary hypoperfusion. And coronary hypoperfusion in combination with increased wall tension on the RV will produce RV ischemia. And then later on, this will lead into a vicious cycle. So what do you have to do? You have to do is to stop RV dysfunction. So there are syndromes of pulmonary embolism related to the hemodynamics, systemic hemodynamics, and venous hemodynamics. So if the embolism is more than 50% obstruction of the vascular bed, there is expected to be hypotension, systemic hypotension. At the same time, there will be RV dysfunction, RV dilation, septal deviation to the left side, and diminution of LV cardiac output. The other subset is what we call submassive. The anatomic obstruction ranges from 30 to 50%. The blood pressure is normal. There's no evidence of systemic hypoperfusion. The RV is dilated. The septum is deviated to the left side, and the LV is also small in size. There is a diminution in the cardiac output count from the LV. And then finally, this is what you call a mild pulmonary embolism, normotensive pulmonary embolism. You will see that the degree of obstruction is less than 30%. The blood pressure is normal, and RV hemodynamics is also normal by 2D echo. So when you look at the profile, this is a large study. This is what you call the ICOPER, International Cooperative Study for Pulmonary Embolism Registry, countries in the US and countries in the Europe. You would see in here that about 5% is massive PE. The mortality of this is about 58% at 3 months. The other subset is called submassive P, about 40% of the population. Mortality is 21%. And then this is the minor P or the mild P, about majority of the population, 55%. There's good prognosis and there's no mortality. And therefore, the management should be dependent on risk stratification. And your risk stratification is dependent on two: analysis of your systemic circulation, at the same time, analysis of your RV hemodynamics. And you can form your subset: minor, submassive, and massive pulmonary embolism. What are the results of thrombolytic treatment in PE? So there was faster resolution of the thrombus. There was significant reduction in the PA pressure. There was significant improvement in perfusion of the lungs. And then it appears to reduce mortality in patients with massive pulmonary embolism or cardiogenic shock. And in patients with acute PE with normal blood pressure and 2D echo signs of RV dysfunction, it has been shown to reduce mortality in recurrent PE. This is the area of controversy. But up to now, there are evolving data, especially in 2014 and 2015. I'll be reviewing it with you that there is now, you can say that's a little bit of convincing evidence that thrombolytic treatment should also be tried with the submassive pulmonary embolism. Other effects is that it does not reduce mortality in hemodynamically stable patients, so it is not used for subset 1 and subset 2, meaning the minor and controversial with the submassive pulmonary embolism. And then thrombolytic treatment possibly improve hemodynamic response to exercise. Let's take a look at the lung model. If you have a saddle pulmonary embolism, what are the consequences? There will be no perfusion in both lungs. So if you do thrombolytic treatment, whether it be mechanical, fragmentation, or pharmacological, or combination of mechanical and pharmacological, this is what happens. You fragment the thrombus, and therefore you will create channels, and they will therefore restore some blood flow. Let's take a look at one lung occlusion. Try to fragment this thrombus, distribute it into different places. You create a channel for blood flow, and restore some perfusion in some of the segments. Another model for a segmental pulmonary emboli. You fragment that into a few pieces, and then you create a channel and therefore restore some blood flow. Or you can do a local thrombolytic treatment, and then you will be able to deliver higher concentration of TPA with a lower systemic dose. And then it will, theoretically, it will dissolve faster at the use of lower dose of TPA. Or you can aggressively go into the thrombus, poke it to the wire, and through the wire you can insert an infusion catheter, and then deliver the thrombus deliver the drug intrathrombus. This is what we do with the ultrasound delivery system, or the ECOS, or the ultrasound-assisted thrombolytic treatment. So you go with the wire, penetrate the thrombus, and then put the infusion catheter. Into the infusion catheter, you put a probe with ultrasound probe at different segments, and then you will deliver the ultrasound into the thrombus, and you will therefore separate the fibrin. And as you separate the fibrin, there will be more surface area where the TPA would act, and therefore there is better resolution of the fibrin with shorter time, at the same time, lower dose of the drug. So when you look at catheter-directed thrombolytic treatment, what is the rationale? You have to maximize thrombolytic effect, at the same time minimize the amount of drug dosage and therefore reducing complications. There were initial 4 studies. We'll be looking at the higher evidence study and meta-analysis towards the end of the lecture. These are the initial studies using catheter-directed thrombolytic treatment. At the time, in the 1990s, UK was the most popular thrombolytic agent that was used until there was some issue of viral contamination, at which time the TPA overran the popularity of the UK in the use of thrombolytic treatment. There was 98% clot lysis. There was no mortality, no bleeding complications with UK, but there was significant bleeding complications with TPA. And this is one particular case that a long time ago during my fellowship, you will see in here, that the catheter has been placed in the right PA. You would see that there is no perfusion of the middle lobe as well as the upper lobe, about 75% of the lung. On the right side, there is absence of perfusion. So that's the pigtail catheter, and after infusion, you will see restoration of blood flow in the upper lobe, and there is perfusion up to the apical segment. Percutaneous embolectomy and pulmonary embolism use a catheter that remove the thrombus and or fragment existing thrombus into smaller sizes. Fragmentation should result in PVR. I have shown that schematic model that I use, and therefore it will increase pulmonary perfusion. And the indication for this is the presence of shock, meaning massive pulmonary embolism, other signs of systemic hypoperfusion, and those who are not candidate for thrombolysis, or meaning systemic thrombolysis or open surgical embolectomy, or embolectomy is not being offered or done in that particular institution. The embolectomy device that we use for PE, it is classified into those with that do not remove the emboli, but just fragment the emboli into smaller pieces. This is the Arrow-Terotola thrombolytic device, a rotating basket, and just a simple pigtail fragmentation device that we can use. Any angiographic pigtail catheter, you could just agitate the thrombus and then break it in smaller pieces. Again, this example, so the pigtail. So you go into the thrombus, poke it to the wire, and then put the pigtail, agitate it, and therefore you will fragment it in smaller pieces. At the same time, you do adjunctive thrombolysis, and therefore there will be more channels for the TPA to go into the more distal peripheral branches of that particular segment. A pigtail catheter has been placed. You would see absence of perfusion, the pigtail there, and then you will see restoration of blood flow that was the baseline. The second category is rheolytic thrombectomy device. I don't have the time to discuss with you the rest of the details, but here are some examples. This is the Helix Clodbuster. There is an impeller at the end of the catheter, and this one is connected to a continuous infusion of saline to dissipate the energy and dissipate the thermal energy that is generated by the thrombus, at the same time also to disperse the blood clot at the same time as it is being fragmented. Because of the impeller movement, it will create a vortex, and it will suck in the thrombus, fragment the thrombus into the impeller, and then eventually into the catheter. This is a thrombolyzer. This is, I think, developed by the Harvard University. I don't know if they have continued on with their experiment. This is a simple catheter with slits at the end, towards the end. If you subject it to several thousands of RPM, you would open like a basket. And therefore, as it opens the basket, it's softer than a wire, and therefore it will tend to break into the thrombus at the same time, suck the thrombus into the lumen of that particular catheter. Here are examples from the initial experiment. You will see in here a lateral thrombus, upper, then RDPA, and then right middle lobe. This is the finished product. You will see restoration of blood flow in the upper lobe as well as in the middle lobe. Aspiration thrombectomy device. This is the third category. And it was popular in the 1990s before the advent of the more simpler ones. The Greenfield, this is a large sheet. Use about 16 French. It's a very large sheet because the catheter is 10 French with a suction cup. It's a 7 millimeter suction cup at the end. When you look at the two studies at that time, it's a small population, One is consisting with a total population of 46, success rate was 76%. The other smaller one, the total number of population was 18, with a success rate is about the same, about 75%. This is how the Greenfield embolectomy device looks like. It's the suction cup. You do it at jugular or a transfemoral, and then you go into the thrombus. So you go into the right away into the thrombus because you have to suck the thrombus. So after the angiographic contrast introduction, and then you verify that the cup is positioned within the thrombus, so you apply suction now. There is a handle at the end where you can aspirate with negative suction, and then you withdraw it, and then this was a particular example given in that particular study. A large clot that's being sucked by the 7 milliliter cup and then brought down into the jugular system. This is a particular example. Even without knowing the clinical, the clinical status of you saw that the patient is already in shock. Look at the absence of perfusion bilaterally.
The last one, you have to remove the entire catheter.
Yes, because it's in the cup. So you retain the introducer sheath. Right. You retain the introducer sheath, and then take it as in total. So you would see absence of perfusion here, and then this is after Greenfield filter. Another one, absence of perfusion. After embolectomy, you would see restoration, significant restoration bilaterally. There is some residual of hypoperfusion, but you can surmise that at least more than 50% of the vascular bed has been restored. The number 4 categories, clot fragmentation with angiographic catheters or balloon. You don't need to have a specialized type of catheter. What you have, and then majority of the series showed successful outcome with improvement of hemodynamics and oxygenation, and therefore diminution of morbidity and mortality. So if you use a balloon, you will inflate the balloon, and therefore you will improve the blood flow. At the same time, you will be increasing the surface area of the thrombus, and therefore there will be more area for the thrombolytic drug to act upon. This is a case during my fellowship, somebody with a GBM, about 3 weeks out from surgery. He developed pulmonary embolism and therefore cannot undergo full anticoagulation. So it was referred to us for mechanical as well as low dose UK administration. You would see in here that is the blood clot in the upper lobe. And then in the left lung, there's also a small blood clot in here, but distally there's a little bit of good perfusion distally, but this clot is partially occluding. So selective catheterization of the right side, and then the balloon was inflated in the lower pulmonary artery. That's the thrombus. At the same time, there is inflation of the balloon in the upper lobe, and that's the area of the thrombus. After about 30 hours of post-infusion of UK, you would see restoration of blood flow. And then we decided also to place a filter. And the 5th category is the use of stents. There's only one case report. They used a stent in the right and left interlobar artery. And there was full recovery after 8 months of follow-up. And this is the newer one. I think our institution is trying to get this one. I think we don't have to buy the machine as long as you keep a minimum inventory, like something like you purchase the catheter system. I don't know how many catheters per year that you have to keep so that they will give this to you for free. This is the ecosystem. It is an ultrasound. There is an infusion catheter, about 9 friends. And at the same time, through the infusion catheter, you can insert an ultrasound probe. And there are transducers in here that are equally spaced, equally distributed along the shaft of the ultrasound catheter. What it does is that it will deliver ultrasound energy and will try to break into the thrombus. At the same time, you deliver thrombolytic agent. So what it does is both mechanical and pharmacological. This is a particular study because of the ultrasound agitation of the fibrin. The fibrin tend to loosen. you separate the fibrin. And if you separate the fibrin, the TPA molecules will be acting better on the exposed fibrin, and therefore you see the progressive dissolution of the blood clots in here. This is without ultrasound, and this is with ultrasound for side-to-side comparison. This is a particular example, bilateral placement. But you would see the radio opaque here are the areas of the ultrasound which are visible, and therefore you know where to place the ultrasound probe. Bilateral emboli, that is before the ultrasound dissolution, and that is the finished product after dissolution. We'll see restoration of blood flow bilaterally. And then when you look at hemodynamics assessed by CT scan, initial RV is dilated, and then post-treatment, 2 days after, you would see restoration of the normal size of the RV, and look at the normal position now of the ventricular septum. Let's take a look at newer studies on the usefulness of ultrasound-assisted catheter-directed thrombolytic treatment in submassive PE. This is a cohort study of 53 consecutive patients, intermediate risk, submassive PE, a very recent one, 2010 to 2014, and the primary outcome that was measured in is change in the pulmonary artery pressure. When you look at the results, there was a significant decrease in the systolic and mean PA pressure, about 7.2 for the mean and 11.4 for the systolic pulmonary artery pressure. In terms of the infusion time, it's just about 16 hours. It's about 13 to 16 hours. The lytic dose is very minimal. It's less than 30, about 24.6 plus minus 9. And there was no significant drop in your fibrinogen. The fibrinogen was 406 plus or minus 141. So the critical level is 150. None of the 53 cases showed drop into the critical level of 150 or less. And in terms of bleeding complications, about 9.4%, but there was no fatal bleeding complication. Another one, it's also a very recent publication, 2015. You will look at here, it is 40 consecutive patients, 15 prospective and 30 should be 15 retrospective and 30 prospective. Also the population of submassive PE. Technical success was 100%, and the mean decrease in pulmonary artery pressure was about 50 to 31, so significant drop from about 20 millimeters mercury. And the RV-LV dimension decreased from, ratio decreased from 1.6 to 0.92. Complications, there were 6 complications, but there was no intracranial bleeding. 4 were minor bleeding at the access site, 2 major in the flank and arm, consisting of significant size hematoma. All-cause mortality was 0 at 30 days. There was no readmission for PE after discharge. Let's take a look at the summary of current evidence on catheter-directed interventions. If you look at this comparative study comparing ultrasound-assisted thrombolysis with anticoagulation versus CDI alone without ultrasound, you will see in here that there was no mortality difference. But it is claimed in here that there were fewer complications with the use of ultrasound. Understandably, because you use lower dose of the TPA or other thrombolytic agent. We look at this other one in a subset of submassive PE, again, a randomized control trial using ultrasound-assisted plus anticoagulation versus anticoagulation alone. You would see in here that there were no major bleeding in both groups. And it favors, in terms of RV dysfunction improvement, it favors the ultrasound-assisted thrombolytic group. The largest of the series, systematic review, about 197, use of ultrasound-assisted thrombolytic treatment in submassive PE, you will see that major bleeding is 3.6%. But the problem with here is, in terms of survival or long-term benefit, it has not been elaborated by the systematic review. But there was improvement in RV hemodynamics. But the problem is, improvement in RV hemodynamics should translate to survival. Or improvement of RV hemodynamics should also translate to absence of hemodynamic compromise. Let's take a look at the EBM data. When should we thrombolize in pulmonary embolism? So this is the graph. The prognosis is dependent on the embolism size and cardiopulmonary status. When it is minor, mortality is 0. Then mortality becomes significantly higher when there is evidence of RV dysfunction. Much more so when you go into shock. There is evidence of hypotension as well as RV dysfunction. Much more so when the patient already go into cardiac arrest, in which case the mortality is 70% or higher. So you have to intervene before the patient goes into shock. And that's the problem. Shall we thrombolize patients with submassive P routinely? There are pros and cons. There are those who agree, there are those who disagree. So when you look at the International Cooperative Pulmonary Embolism Study, look at factors associated with mortality of PE. They were able to accumulate about 2,400 cases. So this is a good evidence-based data. It involves 52 North American and European countries, multi-center as well as multinational. When you look at the hazard ratio that will predict mortality in 3 months, AIDS, cancer, congestive heart failure, hypotension, you would see hypotension has the hazard ratio of 2.9, the presence of tachypnea and the presence of RV hypokinesia about 2. When you look at mortality and divide your subject into hemodynamically unstable, meaning hemodynamically stable is that there is both RV dysfunction and hypotension, and hemodynamically stable wherein there is RV dysfunction but there is no evidence of hypotension, you will see that the mortality is significantly higher in the hemodynamically unstable, 58% versus 15.1% in the group without hypotension. How about imaging and laboratory parameters as predictors of mortality, early mortality in acute pulmonary embolism? You will see in here, this is the best evidence so far, based on meta-analysis of a large group using 2D echo and CT angiogram. In a CT angiogram, you have to measure the RV and the LV ratio. You use the axial. You don't have to use a reformat of the 4-chamber view because there was one particular study wherein they measured both in the axial cut and in the recon for a 4-chamber view. There was no significant difference in the measurement. So you just use your plain axial cut. So choose the cut that will show you the greatest dimension of the RV as well as the greatest dimension of the LV. So what you have to measure now, measure from the endocardial surface of the free wall of the RV and then bring it to the septum. And then on the other side, do the same. Perpendicular to the septum, endocardial side on the free wall, and then bring it to the septum. And then do an RV to LV ratio. If it is greater than 0.9, there's evidence of dysfunction. In some studies, especially the meta-analysis, that if the ratio is 1 or more than 1, there is evidence of RV dysfunction. Other parameters like BNP, the troponin, and a newer one, the fatty acid binding protein, you would show in here that all of them shows good prognostic role in predicting early mortality in pulmonary embolism. You would see that the negative predictive value is very high, 99%, 93% for RV, LV ratio of 1 or equal to or greater than 1. And hazard ratio is, I think the performance for the biomarkers are better compared to 2D echo and CT scan. And a particular marker called the heart fatty acid binding protein, you would see in here that the hazard ratio is 36. When you look at sensitivity about 89, 82, but look at the negative predictive value is 99%. So in terms of prognostication, I think this is I think this one will, I think in the future, with more studies to come, I think this is one that they will use for stratification of pulmonary embolism. So let's take a look at CT. Can we use CT to prognosticate pulmonary embolism? A large study, they look at normotensive acute PE. They look at the RVD, the RV-LV ratio of greater than 0.9, then correlated with all-cause mortality, hemodynamic collapse, and recurrent pulmonary embolism. Let's take a look at their study. The CT measurement of RV-LV ratio correlated with the clinical findings. At the same time, also correlated with the RV dysfunction by 2D echo. It correlated with the BNP as well as troponin. But counterintuitively, it was not expected that when you correlate MDCT, there was no correlation with mortality. There was no correlation with hemodynamic compromise or collapse or worsening, as opposed to the rest. Echocardiogram, you would see there was significant difference between those with mortality and clinical deterioration. Similarly with BNP, troponin, as well as the other assay of BNP and combination of BNP and troponin. So I think with this data, when you try to stratify pulmonary embolism, don't make use of the CT scan as your stratification. Make use of 2D echo. 2D echo should be routine, and it could be done bedside. All you have to do is look at the RV dimension, and number 2, look at septal deviation, and then look at the contractility of the RV. Another one, which addressed that particular problem, a recent publication in 2012, they look at about 579 and try to correlate the embolic burden assessed by MDCT, and then take a look at location of the emboli and look at obstruction index. There is a publication in AGR in 2001 called the Quanavli obstruction index. It's very cumbersome. You take note of the area of the thrombus, and then how many branches are occluded, and then take note of the occlusion, if it is partial or complete, and then sum up the score. It's very tedious, but it's good that they have this study, and it was shown by this particular study that if you correlate it with the clinical parameters, all-cause mortality and clinical deterioration, it was found out that just noting the location of the thrombi, whether it is central, lobar, or distal, you would see in here, in this graph, that the hazard increases from distal to central pulmonary embolism. You don't have to specify or quantify the degree of obstruction. Just specify where is the location of the pulmonary embolism. Similarly, with intermediate risk PE, you would see in here, this is the distal PE. Look at the hazard ratio. This is the lobar PE, and then eventually you go up to the central PE. Look at the hazard ratio progressively increases as you go distally and proximally. How about the obstruction index? You would see in here, with increasing obstructive index, you would see that there is no increase in clinical deterioration. So it's useless, as initially proposed, that you have to look at the obstruction index. So you just take note of the location of the thrombi. Is it central? Is it lobar? Or is it distal? What is the evidence for the use of thrombolysis? How about hemodynamically stable patients with acute PE? This is a meta-analysis. RCTs comparing thrombolysis versus heparin. There were 11 RCT, about almost 2,000. 7 used TPA, 1 used UK, and 3 used Tenetec place. When you look at their finding, all-cause mortality, there's no significant difference. There's a difference in the reduction of pulmonary embolism, but look at the absolute risk difference. It's at 0.4%. But look at the compromise, the trade-off. Major bleeding, intracranial hemorrhage, and fatal bleeding is very high, significantly different between the two groups. When you do a risk-benefit assessment and incorporate it with the numbers needed to treat, you would see in here that incidence of fatal bleeding in this particular meta-analysis, 1.3%. And the numbers needed to treat to prevent one mortality from pulmonary embolism, we have to treat 125. to save one life, somebody with PE without hypotension, you need to treat 125. But your incidence of major bleeding is 5.9%. And therefore, if I have to save one life, I will have to harm about 7 to 8 patients with major bleeding. If I have to save one life in this particular normotensive pulmonary embolism, I will have to cause intracranial hemorrhage in 2 to 3 patients. But wait for this. In order for me to save one life, somebody with PE with normal blood pressure, I have to kill more than one. And therefore, there is a closure in the book. Thrombolysis doesn't have any role in PE with normal hemodynamics. No, there is absence of RV dysfunction, there is absence of hypotension. Look at this one. You kill more than you save. So another meta-analysis, this is 2014, 16 trials total, about 2,115 total, and 8 trials, again, the controversial group, intermediate risk group of submassive pulmonary embolism, with a large group, about 1,775. When you look at their data, you would see in here that the sum effect, the pooled effect, the diamond favors thrombolysis. And at the same time, the diamond does not touch the line of no effect, so it should be significant. When you look at this particular large series, this is the largest of the series. It's called this is the European. It's called the PITO. It was a publication in 2014. It was a good study, and in fact, it's one of the feature. It was one of the feature research article in New England Journal of Medicine, sometime in 2014, because they were waiting for the results. You would look at it more than 1,000 population, and again you would see in here that the pooled effect of this is not touching the line of no effect, although the confidence interval limits is not very wide. When you look at heterogeneity, heterogeneity is insignificant, meaning more or less the study population, all of this randomized clinical trials are homogeneous, and therefore the combined effect could be trusted, meaning the effect that it favors thrombolysis could be trusted because it is homogeneous, and at the same time the overall effect, the p-value is less than 0.05. When we look at the measures of therapy, don't make use of the absolute risk reduction, because the absolute risk reduction is 1.7%, because your baseline is 3.8. With thrombolytics, it dropped down to 2.1, and therefore it's just a minuscule, but you have to relate it. Better you make use of the relative risk reduction. It is about 44%. That's also used for drug trials. You don't use the ARR, they use the relative risk reduction. 1.7%, it seems very small, but you look at the baseline, it's 3.8. And therefore, when you do a relative risk reduction, it's about 45%. And again, the other measure is numbers needed to treat. In order to save one life, you need to treat about 59 patients. Similarly, with the intermediate risk group, needed to treat is 67. It's also very good. Relative risk reduction is 52%. How about prevention of recurrent PE? Relative risk reduction is about 44%. Numbers needed to treat is 58. Intermediate group, similarly, the numbers needed to treat 65, less than 100. This is very important. This is the more important part of your evidence-based assessment, the risk-benefit assessment. So when you look at the incidence of major bleeding and intracranial hemorrhage and numbers needed to treat to prevent one mortality and multiply them, you come up with the following numbers. You cause about 5.4 major bleeding for one life saved. And you cause one intracranial hemorrhage per one life saved from pulmonary embolism. You caused 5 major bleeding per 1 recurrent pulmonary embolism that was prevented. And you caused 1 intracranial hemorrhage per 1 recurrent pulmonary embolism prevented. How about the intermediate risk group? You would see that in order to save 1 life, you cause 5 major bleeding. In order to save, to prevent 1 PE, you have to cause 1 major bleeding. Is it worth doing it in intermediate risk group? Let's take a look at the PETA trial. This is the European trial. It's a randomized double-blind, so it should be very good. A very large population. It's a 2-arm study, 506 given tenetecplase, and then the placebo because they're double-blind. They have to use placebo. When you incorporate now the adverse effect in the numbers needed to treat, this is what I want you to look at for you to decide it's worth doing it in the submassive pulmonary embolism. Per 1 life saved, you have to harm 3 to 4 patients in terms of hemorrhagic stroke. Another meta-analysis, 15. This is the European, very current publication, 2015, more than 2,000. Again, it favors thrombolytic treatment. When you look at the high-risk PE, the massive and the intermediate PE, it favors thrombolytic treatment. But again, similar to the initial meta-analysis that we have reviewed, in terms of the hemodynamically stable, it does not favor thrombolytic treatment. And then there's no evidence of heterogeneity, 0%. And to eyeball heterogeneity, in case they will give that in your examination, this is the way to eyeball it. Drop a line, passing through the diamond, that's the pull defect, and then bring it all into all the studies. If it crosses all the study, then it should be homogeneous. What is the thrombolytic agent of choice? There were 6 trials, about 481. No agent is superior to the other one. But take a look at this particular publication, 2015, the same one, when they tried to do a subgroup analysis. Bleeding was less in the altiplase group as compared to the tenecteplase group. So it's better to use TPA, activase, compared to the tenecteplase group. So there was significant bleeding in this group compared to the altiplase. I think the one that we use in institution is this one. So there should be no problem. So let's go now into the interventional treatment, catheter-directed treatment. So this is a meta-analysis. So look at clinical success, stabilization of hemodynamics, resolution of hypoxia, and survival. You look at this one, the pooled clinical success was 86%. There was no difference in the prospective and retrospective studies. And the pooled clinical success was better if there was local thrombolytic treatment. At the same time, the clinical success was better if the local thrombolytic treatment is extended. When you look at complications, minor complications about 8%, major complication is about 2.4%. So it's acceptable. So conclusion, it is safe, but there were some publication and reporting bias. And most of the studies are retrospective. And this is just about a level 2B evidence. It's not a level 1 evidence. This is the more recent one. This is still online. This is the initial manuscript before publication. I think it's published in CHEST about April 18 this year. 101. And then they look at interventions, catheter-directed interventions. And then clinical success is presence of all the following: stabilization of hemodynamics, improvement of RV strain, and survival. And they look at safety outcomes, major bleeding as defined by SIR, criteria, and also major bleeding. When you look at the results, the average dose thrombolytic is very minimal, about 28 plus minus 11 TPA. When you look at clinical success, it's about 86% with the massive P and 97% with the submassive P. When you look at hemodynamic improvement, there was significant improvement in terms of pulmonary artery pressure, in terms of echo, RV strain, and there were no major related complications in terms of major hemorrhage or hemorrhagic stroke. So it's a good study, good clinical success, balanced with absence of major complications. When you look at their mortality, about 6, and 4 of this died due to massive pulmonary embolism, and 2 died because of submassive P. It's not related to the procedure. And then, interestingly, when they compared ultrasound-assisted thrombolytic treatment versus standard without use of ultrasound, counterintuitively, there was no significant difference. But again, you can argue that the data is limited. And then in terms of RV dysfunction, most of them was normalized. In terms of systolic RV dysfunction, most of them showed improvement. What is the guideline? This is the guideline 2012 using the American Chest Chest Association. So for patients with hypotension, there's no doubt you have to give thrombolytic treatment. But patients without hypotension, they do not recommend. And in fact, they use the word against systemic administration of thrombolytic treatment. And then when you have to give thrombolytic treatment according to this guideline, short infusion should be favored, 2-hour infusion. And I think what the FDA approved is using TPA, you have to infuse 100 milligrams within 2 hours, or you have to infuse 0.6 milligrams per kilogram body weight for a total duration of 15 minutes, not to exceed 30 milligrams. And then, interestingly, all this is just 2012. In patients with acute PE, when thrombolytic agent is used, we suggest administration to a peripheral vein over that of pulmonary artery catheter. So we need to have a randomized clinical trial comparing systemic thrombolysis versus catheter-directed thrombolysis and look at clinical outcome, mortality, hemodynamic compromise, and bleeding complications, especially hemorrhagic stroke. And surgical embolectomy, of course, if there are contraindications, thrombolysis or failure of thrombolysis, or there is imminent death, the thrombolysis, you don't have enough time, you cannot buy time, that you have to act promptly. How about filter? There is no recommendation for routine use of filter, except when there is contraindication for anticoagulation. And then if you place a filter, and then later on, the risk for bleeding or the contraindication for anticoagulation goes away, then you have to reinstitute anticoagulation, even in the presence of filter. So we now go to the last 5 minutes. This is the current guidelines, European, and I guess this is the best one because 2014, the EBM is more current compared to the chest physician, which is 2012, so they are 2 years apart. According to this guideline, you have to risk stratify. Presence of hypotension, look at the pulmonary embolism severity score, look for evidence of RV dysfunction and imaging, 2D echo preferably, and then look at the cardiac biomarkers. Look at the BNP, look at the troponin, look at the fatty acid binding protein. If all of these are present, then the patient is high risk. Then intermediate high, there's no hypotension, but the risk stratification, the pulmonary severity score is high, and both RV dysfunction is present as well as cardiac biomarkers are positive, then it is intermediate high risk. Then if it is intermediate low risk, either one or none of the above are present. But clinical stratification is high. How do we do clinical stratification? We don't have time to discuss this, but these are clinical parameters. One is the full version, and the other one is the simplified version. That's using the simplified version, making use of presence of cancer, chronic heart failure, pulse rate of more than 110, systolic blood pressure less than 100, and O2 saturation of less than 90%. If you score 0, it's a low risk. The risk of dying is 1%. If your score is equal to or more than 1, your risk of dying is about 11%. So this is the algorithm that we use based on the European guideline. So first, you have to know, is there evidence of shock or hypotension? If there is, you have to do lysis. So if there's no time for you to do systemic lysis, then that's the time you have to do catheter-directed thrombolytic treatment. But this is the argument. The lungs should receive all of the blood. That's what you call the first pass, because all of the blood need to be oxygenated. The RBC need to be oxygenated. Therefore, even if you place the TPA peripherally, eventually the TPA should go into the lungs. And therefore, some argue that you don't need to do by catheter. Unlike in the brain, the perfusion of the brain is about 50% of the total cardiac output. Or the heart is about 10% of the total cardiac output, and you have to do a local treatment. As opposed to the lung, by first pass, all of the RBC should go into the lungs. So if there's no evidence of shock or hypotension, then you have to do your clinical assessment. If it is low, then it's low risk. You just do anticoagulation at the same time. This is candidate for home treatment for pulmonary embolism. But if it is intermediate risk, meaning your score is high, then you have to further stratify using both imaging for RV dysfunction at the same time your biomarkers. If both are positive, this is intermediate high risk, then you have to thrombolize. But if it is intermediate low risk, no need for thrombolization, no need for thrombolytic treatment, that's hospitalization and anticoagulation. Let's go back to the case. So with that information, shall you thrombolize? Systemic versus catheter-directed thrombolysis. Remember your answer from the script concordance. We decided to thrombolize because the systemic blood pressure was just about the borderline 100 systolic. So anytime the patient can drop to 90 or 80. So we decided to thrombolize. The PA pressure was 60. Look at this blood clot. Look at this blood clot. Look at the hypoperfusion. Look at the hypoperfusion. There's better perfusion of the left lung, but there's hypoperfusion in the upper lobe. Then we did a low dose TPA, 100 milligrams per hour, to the pigtail in the bifurcation. After just about 19 hours, you would see that we're able to drop the PA pressure to 20 millimeters mercury. Remember, that's your goal for treatment. Drop the PA pressure. And then after 22 hours, you would see that hemodynamics has been normalized. PA pressure is in about 21. The cutoff is about 18 or 20, so this 20 is the cutoff, so it's almost normal. And look at the perfusion. It's almost restored, much more so with the left lung. So, any question?
Wonderful review. Wonderful. Thank you.
Dr. Ray, just to summarize, when the guys, on IR get called in the middle of the night to do a catheter-directed thrombolysis, what are the exact questions?
Risk stratified. If both there is if the patient is in shock, there's no question. Somebody with massive pulmonary embolism, evidence of RV dysfunction as well as hypotension. There's no disagreement. the area of disagreement will be the submassive P. We have to substratify submassive P, meaning we have to look at both. Is there evidence of imaging evidence of RV dysfunction by 2D echo, as well as the biomarkers are positive? If both are positive, there's no question we have to thrombolyze. And again, it will be a judgment call on the subset. It is intermediate risk but low, intermediate low, meaning only one of them is present, meaning there's no evidence of RV dysfunction, but the biomarkers are positive or both are negative. But the severity score is high.
Yeah, it is interesting, because the doses, I think that it's always been, the issue of giving low dose TPA. Because what happened, the byproduct of the TPA are also anticoagulant, and that's what happened with the delayed bleedings that they got. And at the beginning, it was a limiting factor to TPA. Now, the doses, the people from the MICU, which are the people that most ask them to do these cases, are usually higher than the one we see here, because I have not even 100 milligrams. 70 bolus and 30, by infusion.
I think it's rather high.
It's super high.
Yeah.
But they give 100 milligrams when they do it intravenously. So probably what we need to do, we talked about this before, in the sense is try to talk to them to see if we can have a universal protocol or something to have. I think that the overall thing is when the patient is symptomatic, with hemodynamics and stable and everything, that would be the rationale for us sending the patient. And technically it's something simple to do. But the thing is we need to, have we had any adverse events in our patient that we treated?
I don't remember. Maybe this minor bleeding in the access site in the groin, or a little hematoma in the neck.
Yeah, well, that's another big issue,
But they're automatically going to be intermediate, I think.
Yeah. Yes.
They call us, they're automatically intermediate, right? Because they're tachypnic, they're hypoxic. They're automatically going to be intermediate on that chart because when they call us, they're tachypnic, they're hypoxic, they probably have cancer. I don't know. It's 3 of those points on your scale.
Make sure they have an echo. When they have an echo or they have right heart strain or something, they always get troponin.
Until I see your troponin and you're being I'm not going to call you.
Well, Dr. Beta, if you make the decision high intermediate risk or high risk, it sounds like it's clear you should thrombolize. When should we do catheter-directed thrombolysis? I was trying to parse this out with your information versus systemic thrombolysis. When we say we decide to thrombolize, that doesn't mean they directly come to the
I think there are several factors because for us to form our team, you lose at least 1 or 2 hours. Why us if they give that in the ICU, their bolus, they can just give it right away.
Right.
So you have also to take into consideration how fast can you act.
Right.
In terms of the clinical status of the patient.
Right. Just so everybody who's on call is clear, a lot of times you're a high risk, they're a high risk, that's fine, but it doesn't always mean that you're coming to IR for catheter-directed thrombolysis and getting the
or other situations when they call from the ICU and there is an ongoing procedure in the vascular surgery or ongoing vascular procedure in neuro, you have to wait.
Yes, sir.
So you have to talk to them. Can you buy time?
It would be nice to have a protocol that we all follow through, instead. Obviously, the indication is not a problem of thrombolysis. But we need to clarify the route, and the timing, That would be a good thing.
I think we could adopt a lower dose based on the first pass. That the first pass, all of the blood should go into the lungs. As opposed to thrombolysis for stroke or thrombolysis for acute coronary syndrome.
And I don't know, I'm sure that they may have updated that because the last time I did one, it was lower dose. It's lower than 100. But several times I've done it before, it was 100 milligrams, which is a huge dose.
Yeah. And based on the evidence, we should avoid tenetec plays. We should favor TPA, RTPA.
That's the one we have.
Yes, that's the one we have.
I don't think you got it. never used it before. I don't know if we have. It was very good.